This
I
conference
might
will now
actually have
be
to find ways
recorded.
to fire you. Probably not going to be hard though.
This conference will now be recorded.
Just me,
This
bro.
conference will
Get
now be
Friday night
recorded.
and Saturday night off.
This conference will now be recorded. This conference will now be recorded.
My insurer?
I thought you went to what's your turn?
All right, you're
Your
recording.
turn.
Or, I'm
All right.
sorry, I'm deaf and retarded today.
No, if you went to the dentist, you could enunciate properly.
Even if I did go to the dentist, I still would enunciate the same.
Except for his mouth would have been way more swollen.
No, I
He'd
don't
have been
know.
sign languaging you.
I can do that too.
Okay, children, are we ready to do lecture?
Yes, Daddy.
Dude, don't ever say that again. Don't say it like that again. What just happened, dude? My
not
goodness.
safe. Christine is not safe.
He was driving a white van the other day.
That's crazy.
That's not my choice, bro.
Okay. Like, do you guys have any questions on our previous lectures? Does anybody have any questions when it comes to like abdominal or chest wall trauma or anything that we've covered?
So pretty much if you see bruising on their stomach, you better.
Yeah, have a high
You have
index.
a high
Yeah,
suspicion.
for sure.
Okay.
High suspicion, right? Be thorough with your exams. Put your hands on people, on their bare skin. Do a good assessment. Press down. Don't just patty cake it, right? Know what you're looking for and why you're looking for it. It's better to be like, I don't know, it's better to be methodical and slower than just rush to a physical exam that you just like suck at, right? I'd rather see you guys take your time and do a really good, thorough one. Have we been practicing and learning our skill sheets? No, yes. Some of us, yeah. Yeah, I like honesty. I like honesty.
Depends on what day of the week it is.
Okay, those
Do you want me to
are.
come to the senior center and you can practice?
I can do that.
There you go.
The old people want me to practice on them.
They won't?
Not Kip.
Hey, we threatened Kip though, like we had her pretty scared. She saw the video of
NPA.
in the NPA, so now she's like, "Don't touch me."
let's do a little bit of reinforced learning real quick before we kick this off, because my mind is not firing off and my energy's a little low as well. So I need to.
Would you like some popcorn?
No,
Yeah, popcorn.
I just threw his in.
Why can't you have
You're
popcorn?
here.
Let's start with this. Can someone tell me what the difference between a normal pneumothorax and intention pneumothorax is?
Pressure on the heart.
Pressure on the heart, blood pressure, good. Signs and symptoms of shock, very good. What's the difference between a pneumothorax and a hemopneumothorax? Yeah, air and blood. Yep, good. Okay. Let's say we have an evisceration and we have organs protruding. Are we putting dry or wet? Good. Good. If it's wet, keep it wet. Good. It's a good way to. If it's dry, keep it dry. Okay. Who remembers their rule of nines? Go ahead.
So on an adult, full head is 9%, full arms are 9%, front of chest is 18, back of chest is 18, or torso, excuse me, and then both legs. I think it's front of legs are 9, back of legs are 9?
Yeah.
Or is it just full leg?
No, I think you're
It's
right.
front and back, right?
Okay, who can tell me what Beck's triad is, the components of Beck's triad, and what disease process it is related to?
Bleeding, coagulation, right?
So you're thinking about the trauma triangle. You're not wrong, but Beck's triad specifically.
So back is for CHF, so it's JVD.
Is it for CHF?
No, it's hypothermia.
No, you're thinking.
Okay, so yeah,
Oh, I-
yeah. So like she
I'm
was.
sorry, tamponade.
Okay, what is a tamponade?
Blood filling the sacrum of artery.
Okay.
So I'm sorry, muffled heart sounds, GVD, and
Low blood pressure.
Oh,
is it low blood pressure?
Yep, good job. Right, it's either going to say something like narrowing pulse pressures or low arterial pressure or hypotension for that, right? Most of the time it's going to be hypotension. Your muffled heart tones. Why? Because now there's a layer of fluid that you can't really hear through. And then your jugular veins. Why? Why do your jugular veins distended? If you just remember,
Pressure.
yeah, anytime that you have pressure that's backing up into the into your neck, into your head, you're gonna have those jugular veins pop. Okay. Okay. Good job. Okay. Well, Shia, since I cut you off, what is the trauma triangle of death?
There's, what my brain farted. You have to keep them warm.
Okay.
Hypothermia,
Good.
coagulation,
Okay.
and I cannot remember the third one.
Yeah, acidosis. And remember, what Mike was saying, like it is a triangle, but this isn't linear. Like point A gets you to B. Like a circle would make more sense. That like they just intertwine all the time. One causes the other, that causes the other, and it's not linear. They cause each other and make each other worse. It's like a negative feedback loop.
You don't have to have one to get.
Yeah. Yeah, my apologies. A positive feedback loop that they just make each other worse and keep going until we intervene. Okay. All right. Everybody feel pretty good. We'll dive into lecture. That was a good little brain exercise for me. Thank you. Musculoskeletal trauma, chapter 32. Thank you, Becca, for these wonderful slides. If you guys have seen the stock slides, they suck. So she did a great job on these. Okay. Our objective is to review the anatomy and physiology of the musculoskeletal system. We're going to identify different types of injury patterns, and we're going to learn how to splint and why it is performed. Back when I was going through school, we actually had to sit in front of back when the state was doing sign-offs, and you had a splinting skill station that you had to pass. And the amount of people that failed it because they forgot to check a pulse after splinting was astronomical. So anytime you manipulate an injured extremity, remember that you need to check a pulse, okay? Because if they had one before, but they don't after you manipulated it, that's a problem, right? We need to address those things. So we're always checking pulses. What is the musculoskeletal system? Before we go on, someone give me some ideas of what you think falls into the system category. Bones, good. Cartilage, good. Some ligaments, good. Good. Muscles, good. All right. Bones are your framework. Joints are for bending and muscles are for movement. Cartilage is for flexibility, and your ligaments connects your bone to bone. All right. Tendons connect muscles to bone. Does anyone need to review this? This is pretty basic, day one A&P stuff. Most adults coming in here already kind of know or have a decent framework on this. But we can review it if we need to. It's not a big deal. By the way, if someone has a question, just ask it, because that means somebody else in here has the question, and they're probably too shy to ask it. Okay, we'll go over the A&P. What is the biggest bone in your body? A femur, right? That's a big, thick bone. So with it being big and thick like that, do we think it takes a little bit or a lot of force to break it? A lot, right? There's some caveats. If you have old grandma with osteoporosis, sure, it might not take that much, right? They can break it by walking. But for the most part, in a decently healthy adult, it takes a substantial amount of force to break a femur, okay? Your metacarpals, your hand, your phalanges, or your fingers. How do we know the difference between the ulna and the radius? How do we know where the ulna is and where your radius is? Yeah, right. And where do we check a pulse? What kind of pulse is this? Radial pulse, right? Radius, radial, right here. Ulna's on the back side. Okay, your humerus is like your femur for your arm. It's the biggest bone up here, and the humerus does count under CDC criteria for trauma centers as a long bone fracture. Okay.
You said the humerus?
The humerus, yeah. If you have a nasty humerus break, those guys go to trauma centers. If you have a ulnar and a radius break that's not that's closed, generally they can wait unless there's something crazy. But humerus, femurs, those guys are going to a trauma center.
I had an open ulna, still waiting, from emergency room.
Really?
I have a scar on the side of my arm.
Yeah, right. These bones, they don't take that serious unless you have CMS compromise. And what does CMS stand for? Just so we're on the same page.
Sensory motors.
Sensation. Sensory?
Circulation. CMS. sensory
Circulation,
motors.
motor, sensory.
Oh, I had it backwards.
But yeah. You have your sternum, which we all know where that is. You have your ribs, your vertebral column. Okay. I don't know why I'm pointing at myself if they can't see. Yeah, sorry. Okay. The big one we need to look at, because that's one of the things that we can really treat, is the pelvis. Again, like pelvic fractures are a very big deal as well. And we get them out here a lot. Like motorcycle injuries generally have a pelvic. Horses, I don't know if you guys know this, but horses are the devil's animal. They fuck people up like I've never seen.
Oh, yeah.
I've seen people survive car accidents where, like, I'm like, damn, that's bad. But, like, you know, those horses will fuck some people up.
1,500-pound horse lands on your.
Yeah,
Oh,
like, fun fact, when I do the rodeo standbys, like, I will hold my bladder and pee my pants before I walk through them horses. Do you guys remember A&P, where your cervical spine goes to your thoracic, goes to your lumbar, goes to your, like, coccyx? No?
7, it's, your C5 is.
Keeps the diaphragm alive?
Lunch
Yeah.
at
Yep.
12, dinner at 5.
Yeah, that's how I remember it too.
And
And then the,
6.
yeah, coccyx.
Okay, what's the nerve that runs around C3 that keeps us breathing?
It's the one that babies are super sensitive to, right?
That's not right.
I don't know. That's a good question. I'll follow up on that.
No.
It's your phrenic nerve. Okay, your phrenic nerve sits around C3. That's why cervical spine fractures are so much more dangerous than like fractures anywhere else. Okay, your anatomy of a bone. The bone is formed of dense connective tissues, vasculature, is susceptible to bleeding and injury, and it's covered by periosteum. I didn't know that. So did you guys know that you have like a vascular system within your own bones? Did you guys did know that? Like actually inside of the bone? Yeah. Yeah. So fun fact, like when we drill, that's why we drill into people's bones, right? When like we can't get a line and they're super sick or they're dead, because we can directly access the vasculature in there and give them fluids and medications through there.
Isn't that the whatever, the thing that holds on to the item?
I think so, yeah.
So it holds it in there instead of just falling out.
I believe so. Joints is where your bones meet.
So osteoporosis, does that affect the perosteum? Is that where the breakdown is?
I would assume so, because it hollows out the inside and it weakens all your like connective tissues in there.
So it hollows out that nutrient artery system like that?
I would actually say it probably hollows out the connective tissue more. It might. You guys might be right. I'm not sure.
Why is it bones on the outside? Right,
Yeah.
so osteoporosis, I mean, that's increasing or just porosity of the bones in general.
Does anybody have like a family member that's had like osteoporosis? Okay, well now thanks to Ozempic, you will in the next couple of years for sure, because the amount of people that are taking GLPs that are now having subsequent osteoporosis is through the roof. That's why they emphasize so much like protein and lifting to help that bone density stabilize. But no joke, man, you'll get like grandmas with osteoporosis that'll like step wrong and their femur will go, and it's pretty nasty. Yeah. Not taking a shot at Ozempic by any means, dude. I actually think it's a wonder. Like it's going to prevent a lot of heart disease and stuff like that in the future, but they just need to be careful with their protein intake and lifting.
Maybe I need to refresh that.
Also be like, is it vitamin C or calcium?
Calcium, I mean, actually all of it. Vitamin D, vitamin C, calcium, magnesium, they're all like play a vital part. Calcium specifically, obviously in bone density. Okay, how much can your bones bleed?
A lot.
8 to 10 pints of blood in the human body. Roughly how many liters?
4 to 5.
Yep, 4 to 5, okay?
So, I didn't know.
Okay, 20% of that leads to decompensated or severe shock. So how much is 20% of 10 pints? Oh, son of a gun, dude.
Pints.
2 pints. Yeah. So that's not a lot of blood you can lose before you start to decompensate.
So many pints are in a liter?
I think this is like.
4 pints in a liter.
I don't know, but I think it's like this because I think there's like 2 quarts in a pint and I think, or 2 quarts in a liter.
No, I
and
thought
think
there were
liters in a quart is more.
There's 4 quarts in a gallon. right?
Is it 4? Steven, you feel good about that
4 liters in
answer?
a gallon roughly.
4 pints in a liter.
What's the question?
I believe it.
How many pints are in a
How many pints are in a liter? 2.113.
Okay, so we got 2 pints in 1 liter.
So right.
Okay. All right, good. This is the shit that I'm excited to talk about, okay? We've been talking about hemorrhaging and blood loss. Boom, 3 to 4 pints in your pelvis alone. Is that over 20%? Yes. You can go into decompensated shock in the pelvis alone, so we need to be good at checking this and treating it. Femur, 2 pints. Tibia, 1 pint. Remember when I was telling you guys you can hemorrhage into your whole body cavity and never drop a drop outside and die? This is what I'm talking about here. These are big muscles, big open cavitative areas. We need to be doing good assessments on trauma patients to catch these. Okay?
I have a weird question.
Yeah.
Maybe I should already know this, but like, when you have internal bleeding, it's not leaving your body. Obviously, it's not in your circulatory system. Does your body reabsorb that fluid and it ultimately ends up back in your circulatory system, or does it get pissed out or something?
No, it doesn't get pissed out. Like if you make it to surgery, they're going to be giving you blood while they're sucking that blood out of you, because when that
Right.
blood is in your abdomen, like it's going to be extremely irritant. It's going to be like a pretty nasty irritant. Think about when you swallow blood from a nosebleed and how you get that stomach ache after, and how it's just like, it's the same thing. I mean, your body can reabsorb some fluids and even air, like it can dissipate air over time. But if you have a massive hemorrhage, like, and you're just pooling in there, no, the surgeon's going to go out and suck that out. Okay. Here's some skeletal structures, your axial skeleton. We know the difference. Extremities, and then the middle. Okay. Classifications of shape: long, short, flat, and irregular. What did we say about the scapula in our last lecture?
It is the hardest one to break.
It's one of the hardest bones to break. So if you have a scapular fracture or high suspicion of it, like they probably need to go to a trauma center. Okay. So your long bones, like I said, your humerus is one of your long bones. So is your femur.
Can you go back one slide?
Yeah.
Axial, thank you.
No problem. Does everyone feel pretty good? Okay. All right, bone healings. Breaks cause soft tissue swelling and blood clots. We know that's part of the clotting cascade. Swelling is your body's natural reaction, and it's that's where it sends like the fighter cells in there to heal yourself. In fact, most bone breaks don't need surgery. Most bone breaks, they literally just put you in a cast and let you heal on your own. Interruption of blood supply causes cells to die at the injury site. Cells further from fracture rapidly divide, forming tissue that heals the fracture and develops into new bone. How many of you guys have had a kid that has broke a leg or something? Nobody? Who? Your daughter broke her. Yeah. My kid broke her leg, and they're just like, yep, 6 weeks, good as new. Be a little soft on it. And same thing though, The bones heal the same as all the other tissues do, right? You need like good blood flow. This is why diabetics don't heal well, by the way, because they have like a lack of circulation peripherally. That's why they have like small wounds that turn into big gaping wounds, because they don't have good blood flow and oxygen delivery to heal that. So same, you have somebody with osteoporosis, certain cancers, diabetes, their bones are not going to heal very well from these. Okay, types of muscle tissues. We have smooth muscles, cardiac muscles, striated muscle cells. What are going to be like your striated muscle cells? Your heart's going to be your cardiac muscles, and they put this in its own because the heart's kind of its own little entity, right? Like it's the only one that has like automaticity where it just wants to beat, and that's why you can do like heart transplants, and it doesn't need the rest of the body to do it. So cardiac muscles are in a little bit of a different category on their own. Your striated muscles is like what Andy uses to lift his Harley. And by the way, Andy let me sit on his Harley, dude, and I couldn't touch the sides. So he picked it up for me so I could act like I was driving it. Dude, this man is Uncle Andy to me forever. What's up, Uncle Andy? How you doing, dog?
Is that like the highlight of your day?
It is, dude. It is.
Oh.
I sat on 2 Harleys today, bro.
Now he wants one.
All
Did
right.
you make the vroom vroom sound?
So no, he did not. So skeletal muscles are voluntary. What does that mean?
You can move them on your own. Like,
Yeah, like you're telling it to move, right?
Yeah.
I'm telling my bicep to curl this thing. Okay. Smooth muscles are involuntary. They just exist. And then cardiac muscles, like I said, it's like myocardial. It's its own realm because you don't have to tell it to do anything, and it just does. And they're formed a little bit different. Not a lot, but a little bit. Okay. Cartilage helps form flexible structures in the body. What do we have that's made of cartilage? Our noses.
The connecting from your ribs to your
Yep.
sternum.
Joints?
Yep.
It's in our joints.
Yeah, joints.
Yeah, we do. What do they do for the joints?
Ears.
Kind of act as a what? It's like a shock absorber, right? So what happens to people who say, right, their cartilage is all jacked up, like they have a hard time walking because it hurts. Tendons allow for power of movement across joints. I wish Deputy Campbell was here, because you don't realize how important tendons are till you rupture one, and then your muscle shoots up at the top. So when Deputy Campbell ruptured his brachial tendon, his bicep was up here at his shoulder.
Ow.
Yeah.
In
Really?
a
Yeah,
strong-
something like that.
In a strongman competition where a guy was holding the pillars,
Yep.
his same thing ruptured, and you see his bicep.
Yep.
Go up.
If you watch those videos of those guys that like bench press a ton, not Andy. This has never happened to Andy. There's not enough weight in the world for Andy. But those guys, and those pec muscles rupture, and what do? They shoot way up here at the top, right? So
Instant movement.
yeah, like those tendons, once they rupture, like the muscles are not held in place anymore.
Now you gotta get in there and go surgery.
You do?
Stitch them all back.
Yep. And some of them are not even repairable, depending how fast you get in. Ligament support joint by attaching bone ends to bones. That is a good way to put it,
Ligaments are gate.
because it's holding bone to bone. Okay. Tendons is muscle to bone. Ligaments is bone to bone. Okay. Different types of mechanism of injuries. Your direct forces causes crushed tissue and fractures. Indirect causes injuries to knees, long bones, femurs, pelvis, and spine. And then your twisting forces causes stretching or tearing of muscles and ligaments, as well as broken bones. And I mean, these are all also pretty self-explanatory, right? Especially the twisting one. Has anyone blown an ACL out or an MCL, LCL? Okay. Yeah, that always comes from a twisting motion. That's always like, I'm loaded, I twist, pops.
I know they hurt that.
Yeah, I'm sure. I don't know. I still have all my ACLs intact for now. For now. All right. Fractures are any break in a bone, open or closed. What do we think the difference between an open and a closed fracture is? That's right. In skin, out of skin. Okay. Types of bone fractures. You have green stick, transverse. What does that say? Comminuted? Yeah, I don't know. Spiral and compound. Pop quiz. Who can tell me who gets green stick fractures? Right. Why? Right, they're little twigs, dude. You take a green twig and you like, yeah, it's gonna splinter, but it's also gonna go back. Green stick fractures heal very well, especially obviously in young kids. You're not gonna see it that much in adults. Transverse, the name is self-explanatory, right? It's like transversing through. This just looks like a hot mess, dude. This would be really, really hard, depending on how big it is, for a surgeon to fix. Like they would have to, I don't know, they'd have to put like several plates, but if those bones are not capable of healing anymore, like,
you just cut it even?
I mean, I suppose you could shorten, right? Like they can do quite a bit of stuff, but when you have these and you have them in large sections, that's where your amputations come from fractures, right? When you have large amounts of bones that are not salvageable, that's when, like, at that point, you're going to have blood flow restriction. You're going to have all sorts of issues, severed arteries, severed veins. And if the bone is not salvageable in that fashion, like that's where you're going to get your amputations from. Spiral fractures come from that twisting motion, and then compound. Generally, you're going to see that come out of the skin too. You can have a compound inside, but we will talk about displaced, angulated, shortened, and rotated more in depth when we talk about treating these. Have they talked about like how to tell if someone has a dislocation versus a fracture?
In the book.
Yeah, in the book. Okay, so like how if I called you guys and I was outside, how would you, for a lift assist, whatever, dude, and how would you determine whether I had either a fracture or a like dislocation?
Is it moving or not?
Okay. Sometimes it's not super easy to tell, especially if it's like not.
It tells you to not focus on that, to just assume it's fractured. And
Okay. So I'm going to give you guys some tidbits. If you see my legs, my little legs here, they're even, right? Okay, same length. Okay. If I am shortened on one side and rotated in,
Fracture.
He does talk about that.
Dislocated.
does it
Oh, yeah.
dislocated, right? Because, and generally you can feel in the back of the hip here, the femoral head, if it's popped out, and you can feel it back here. So shortened, rotated, go to the glute, feel it, press on it. If you feel a hard mass back there, you have a pretty good chance that that's dislocated, okay? If you're shortened or even elongated and rotated out, most of the time that's going to be a fracture. These aren't absolute rules. You can absolutely have a fracture if you're this way still, but your most common is going to be shortened and inside. You're going to be dislocated, rotated, you're going to have a fracture. And a lot of times what we see is if you look on these bones at the top, it has that little ball at the top. What do we call that? It's the femoral head, okay? And it sits in that socket. Old people break that fucker off all the time. They break that off all the time. Femoral head fractures. It's a very, very common fracture you'll see.
Yeah, my grandma broke it. Both of them.
At the same time?
No, it was like
Oh.
one, and then 6 months later, she broke the other one.
Yeah.
What do they do for that?
For a dislocation or femoral head fracture? They go in and you have to have surgery. It depends on how bad the fracture is, right? If you just have like some fractured lines in there, then they can immobilize it and let it heal. But if you have a bad enough fracture, they'll go in and generally put like a titanium cap on it or give you like a titanium one, screw it into the bone, and then you have a titanium femoral head. Yeah.
I think I have a pretty badass picture of my grandpa's.
Dude, I put your grandpa's hip in at least 5
I
times.
remember every time Oh, yeah. That's how I remember the foot thing.
Yeah. So his grandpa probably once every 4 months would pop his hip out of place. Yep. And so think about this too, right? Like you have muscles and tendons and everything. Well, once you stretch that out, think about being like an old man who's not doing squats on the daily basis or working out. Once you stretch that out, it's not going to be the same. It's not going to hold in place the same. You're going to be way more susceptible to do it again. Okay, dislocation, coming apart of a joint. I think we all understand what the word dislocate means. Okay, sprain, stretching, and tearing of a ligament. Strain is overstretching or overexerting of a muscle. And like, I don't care what anyone says, like a bad ankle sprain, that shit sucks. They need to come up with a better word than just like, I strained my ankle. Okay, so assessment tips, rapidly identify and treat life-threatening conditions. No one is going to die from a hip dislocation, even a femoral head fracture, okay? So you got to do your ABCs first. This is what would be constituted as a distracting injury. Be alert for injuries besides the grotesque wound. That's a distracting injury. Don't get caught up on the fluff when there's other shit that's going to kill them. Don't splint your patient to death. Address life-threatening conditions first. And this, honestly, we should take it out of the EMT book and put it into the paramedic book. Because every time like this happens with paramedics, if they get on scene, somebody's really fucked up, and the first thing they want to do is start drawing up all their drugs. When you're like, bro, we need to address the ABCs and do a bunch of shit before we even do that. So don't get caught up and let your patient die because you're trying to splint something that looks bad. Perform a complete examination. If you have a real legit trauma, right, the whole strip and flip thing, don't skimp on that. Yeah.
So, if they, internal bleeding is considered an immediate life threat, so then like a pelvic binder, we would put that on during that initial.
Yep.
Okay.
Yep. Yeah, if I'm going and I'm doing an assessment and it's the difference between like twigs and logs, right? We can run over twigs, but you have to stop and address the log in the road. And as we saw, you can bleed enough to go into decompensated shock into your pelvic cavity. You need to address that.
So that one and then the femur are kind of like the only splinting that are life-threatening related.
Yeah, even then, there's not, other than a traction splint, there's really not anything else you're going to do for a femur fracture. Unless they're like squirting blood, then you can put a tourniquet on them. Okay? Treat all injuries with signs and symptoms of a fracture as a fracture. Worst case scenario, you splint someone that doesn't need it. Okay, doesn't matter. They're going to get scanned at the ear. I'm going to take it off. Not a big deal. Traction splint should be applied to a suspected femur fracture. Splinting an extremity with suspected fracture helps prevent blood loss from bone tissue, and it helps immobilize them so they're not going to further injure that. This is the big one I was talking about. Assess CMS before and after. So I'm going to check the pulse before I splint, and I'm going to check one right after I splint, and I'm never going to vary. That's a golden rule.
All right, so femur fracture and pelvic fracture.
So pelvic binder, yes.
Femur
Femur fraction, fracture.
So I
maybe.
would only do the pelvic binder over the traction splint, because if you do both,
They
then
can't do
theoretically,
both at the same time. I don't think.
that's what I thought.
Have you guys gone over your traction splints yet?
No.
Yeah, sort of.
Not the
No.
line.
I don't think so.
Look at the minor here.
Here.
Oh,
No.
no.
You guys have not
They're in
gone
the
over traction
book,
splints.
but
Okay.
not-
So these traction splints will hinge here, right, and pull traction down. If you have a really bad angulated or like a really bad pelvic fracture, that force can make it worse, okay? So the literature is a little bit split on this. I'd have to look it up in your book, but I'm going to say this is for isolated femur fractures only, okay? Your traction splints are for isolated femurs only, okay? Yep, and it can't. And that's going to change in the next couple of years too with the introduction of antibiotics pre-hospitally. But if you have a bunch of bones protruding out, then you cannot pull that femur back together.
What kind of trauma would you expect there to also be a pelvic injury. Like
Like car
a
accident.
bilateral femur fracture from a car accident will probably have also a pelvic fracture.
Yeah. So if you have bilateral femurs, it's like a 90% chance you have a pelvic fracture. That comes from the TCCC committee as well. So who is going to be the most common person we see that on?
Car accident.
Chicks
people
that
that
put
do
their
that.
Chicks that put their feet up. Get your fucking feet off the dash. My goodness. Grow up, Peter Pan. Grow up. Yeah. But you can have it from a lot. ATV accidents yield a lot of femur fractures, ejections, horse injuries. Honestly, the one I've seen the most for, pelvic injuries. The most I've seen for pelvic injuries are people who have been rolled over by their horse and it crunches their pelvis to a million little pieces. Okay. It's a devil's animal. We are going to go over some splinting techniques. In the top left there, it's showing you how to use a triangle bandage to splint. We're going to go over that. The middle picture there, it's called a SAM splint. That's pretty much like the industry standard, and we'll teach you how to use those as well. And SAM splints are very versatile. They can be used in a ton of different ways. And then in the top picture right there, you see the traction splint. And that is exactly what it sounds, right? If you have an isolated femur fracture, what is happening, right? That bone is broke, but you still have all the muscle and tendons and cartilage and ligaments around it, right? So what's going to happen if my bone is used to doing this and now I do this?
The muscles are pulling.
It's going to pull it, right? Which is why when you see a femur fracture, it's going to be bigger and it's going to be shorter than the other one, okay? And what the traction splint is doing is basically pulling that back into normal alignment.
I've got to see that.
Yeah.
And, a kid was driving down this side road on the old apartment I was on, in a Cadillac and rear ended the chip truck, and it broke his femur.
Yeah.
We had to do traction on it.
Mhm.
There was not a single drug they could have given him. He was screaming the whole time.
Oh, I bet if I give you 250 a ketamine, you won't remember a damn thing. Yeah, it's right. Try
So what's the blue one?
That's the airbag one.
yeah. So the kid with the blue shirt.
Yeah.
Yeah. So that's gonna be we call them vacuum splints. So essentially, you mold it around them, and then you take all the air out of it, and it just like perfectly forms to their arms. These are really good. We use them a lot. They're ungodly expensive, and we never get them back. Yeah, those are your vacuum splints. Yeah, they're super expensive, and we write our stuff all over them. Dude, I know those dickheads at Remza go, because Renown has like a place for all the EMS equipment that comes in. I know they go pillage our vacuum splints all the time. Oof. What kind of fracture would we call that?
Compound.
Okay. Compound for sure.
Open.
Okay.
Is that an amputation? Like,
That's probably salvageable, I would say.
no, like I'm sure it's salvageable, but like it looks like you can see both ends almost completely.
Yeah, no, that's nasty. Like you have it sticking out of two sides there. That surgeon's gonna have his hands full.
They'll have it fixed in 6 hours.
If you're lucky. Okay, why do we splint? Minimizes movement of disrupted joints and broken bone ends, decreases pains, prevents additional injuries, can prevent a closed fracture from becoming an open fracture, and then the big one here is that it minimizes that blood loss. A good splint is going to treat your pain, but more than anything, it's going to keep that from getting worse, okay? And that's what we really want. Little tidbits. Make sure your ABCs are addressed before splinting, okay? Unless that splint is going to directly address an ABC, we are not splinting anybody that's not breathing adequately, doesn't have a patent airway, or is hemorrhaging, okay? And that means we're probably going to treat for shock before we splint too. Okay, if you splint too tightly, you're going to cause that compression of the soft tissue. You're going to cut off CMS, and you can potentially, depending how long they're going to be like that, cause a external compartment syndrome. Too loose of splint's going to be ineffective. So we're going to hit that sweet spot. When we're splinting, we're going to mobilize above and below the joint when we're doing a joint, okay? So What does that mean? That means if we were splinting my elbow because I had an elbow injury, where's above and below that joint? Yeah. Yeah, so I would put a SAM splint somewhere like this, right? I would wrap it back behind my tricep and then down here, and then I would wrap it. Okay, above and below the joint. When we're doing long bones, it's the same, above and below the injury site. Okay? Ooh.
Ooh, that's a good one too.
Because it's a right lung injury.
Yeah. Yeah, that's a bad idea.
That's one that you probably shouldn't splint at all.
I mean,
Splint in front.
yeah, I would just splint the front and stay off of the bones and then wrap around it.
You mean?
Like I would
Oh,
go.
like turn it the other way?
I would do it.
Wrap
Damn,
around?
this thing doesn't work. It doesn't.
Splint, because you'd be splitting here.
Yeah, I wouldn't splint over this because that's gonna be
Right.
super fucking painful. I would splint along this edge here,
And then would you
and then
patch
I'd
that
wrap
with
it here and
gauze?
here. If it's bleeding bad, right? If it's bleeding bad, you can do some pressure. But I mean, that's not bleeding bad. That's pretty controlled. I wouldn't pack or do a tourniquet or anything on that.
But you put something over it, yeah. That's good.
They didn't, when I cut my blade chainsaw, they put me in a splint, but they never even touched, put anything over it.
What's up?
You're in a lot of pain already.
Pretty painful.
Yeah.
to put something
Yeah, it's gonna
like
fucking hurt.
Maybe not like pressure, but like.
But it would probably hurt more to like
Just-
Well,
swap
mine doesn't
around.
dry to that, and it just feel it off.
So saline solution first, saline solution for bandage.
Yeah, you could. I mean, if you get.
I'm just thinking like, cause worst thing that could happen, exactly, that's what I'm thinking is infection.
Yeah,
Put saline gauze over that, no
Yeah.
pressure.
dude. If you have if you have the time to like dress it up and do all that stuff, yeah, by all means, that's good medicine. But
They're going into a surgery suite and they're getting all the antibiotics.
yeah, that's the thing. So note this: anytime you have an open anything, if EMS doesn't give you a broad spectrum antibiotic, the minute you get wheeled into the ER, they're going to open up 2 broad spectrum antibiotics right out of the gate. Now, we carry Ancep, which is a broad spectrum antibiotic that we give to all of our open injuries.
So I really don't need to worry about that.
No, but I would also give you and say you're not wrong that if you have the time to try to cover it in a fashion that's not going to hurt them, that's also not bad medicine. Like that's still good medicine. That's still supportive care.
Especially like if you're like out here where we have such long transports.
Yeah, if you're hours away, like, and you have time, yeah, for
Even
sure.
like Marigold, I mean, it took like what, 40 minutes for y'all to respond and y'all are here.
Yeah. God, I hope it didn't take us 40, but that's definitely possible.
It seems like 40, but it's actually only 25.
It might be right by the time we get.
Well, and it depends if they have another call.
Cardiac, yeah.
Well,
It
and-
took 2 hours for that one call, and
That's
they
what I'm
died,
saying.
but they also were on a call.
Right.
Yeah, so you guys know how this works, right? When you call 911, when your dispatch calls from the mine, it goes to Winnemucca.
Yeah.
Winnemucca pings it over to us.
Depending on where it's at. So does it go?
Most of the time,
Because there's a line that cuts across there, because I've called and gotten Lander County.
well, my understanding is at the mine site.
So it's probably because they're using a landline.
Could be. But it
Yeah.
bounces to Humboldt, then it bounces to us. And then by the time we get out there, if there's someone to escort us at the gate, great. If not, we have to wait for an escort. So it is time consuming.
That's why-
Anyways, sorry, we're
That's
getting
why
off
we always
track.
try to meet you at the gate with the other ambulance.
Right, but regardless,
It
it's
still
worth
takes a
the
while.
saline.
Yeah.
And bandage in that case.
Yeah, if you have the
is what
time.
I'm thinking.
I don't think doing extra is bad if you have the time for it, for sure. As long as you don't get tunnel vision into your ABCs.
Is it screaming?
And you drink fingerless.
Do what?
And you drink fingerless.
Or what?
Playing grab ass.
Oh, okay.
Oh.
All right. Anyways, pillow splints, dude. Pillows work great. And just think about it. Like, if you break a bone, wouldn't you want a fucking pillow under it? It's just a little bit of common
I can't
sense.
understand.
They're using in this middle picture, they're using the other finger as what? As the splint, right? So splinting is all about like your creative mind. There's not a set way to do it. As long as you're following the cardinal rules of above and below the joint, above and below the wound, checking CMS before and after, you can splint however your heart desires. I know some people who splint very beautifully, and I know myself, my splints look like dog shit. Like straight up dog shit. Ooh, realignment of a deformed extremity. This is actually something that's been changing over the years too. Injured joints bones should be splinted in the position found unless the distal extremity is cyanotic or lacks pulses. Okay. What does that mean?
There's no blood flow.
Yeah, that means that they don't have blood flow to that extremity, so that's the one time you're allowed to realign an injury. Okay. If not realigned, splint may be ineffective, causing increased pain and possible further injury. Okay. The old rule used to be, and I don't know what your book says, I'm sorry, but the old rule used to be is you get one shot to realign and get a pulse back, and then you're done, because then you might be causing more trauma.
So, in practice, well, first of all, have you ever done that, realigned a bone in the field?
Not that I can recall for the like express purpose of getting a pulse back.
Okay. Have you for other reasons?
I mean, his grandpa, I've reduced his grandpa a handful of times. But I mean, that's a little bit, yeah, that's a little bit different. Yeah, I mean, don't get me wrong. I've had people that are super jacked up, and just to get them on the gurney, I have to, you know, their leg is this way, right? That I have to like realign their leg to put them back on the gurney. But I've never actually had an instance where I've had to realign to get a pulse back. When you have to do that, just think about like you're trying to realign normal anatomy, okay? So you're just gently pressure to realign normal anatomy.
So slow and steady, not.
Yeah, no, not fast at all. And if you can, yeah, sorry. And if you can, like have somebody feeling for a pulse, right? Because as you're moving it, if you're like, oh, I got a pulse back there, there it is. That's what you want to do.
So you're just moving it back enough to get the pulse?
Yep, just back enough to get the pulse. Just, yeah. And you got to think, right? You have veins and arteries that run along some of these. So if you have a jagged end of a bone and now you're like shearing an artery, you can cause a lot of damage. So this is not something you do in a hurry. Good? No, you're good. Ooh, pelvic injuries. This is good. May present with pain in the pelvis, hips, groin, or back. Cannot lift legs when in supine. Lateral rotation of the foot. What does that mean?
Outside and short. Swollen.
That's for the femur.
Oh.
So somebody tell me what lateral means. No.
Left or right?
Yes. So lateral rotation of the foot. Okay. Unexplained pressure in the bladder, bleeding from urethra, rectum, or vaginal opening. I've actually never seen anybody bleed from externally bleed from a pelvic injury, to be honest. I mean, I saw a dude get shot right by his dick. That he was, but that's a different kind of injury. Other than that, somebody bleeding from it? Damn, that's crazy. Yeah. Yeah, so I think it just comes back to the principle of doing a thorough assessment and stripping and flipping, right? If you're like, oh, I'm not going to take this person's clothes off because I'm shy or whatever, like no, severe traumas like need to be stripped and flipped, and you need to look to see if this is happening. Oh, that's a nasty, nasty pelvic fracture right there. Like you see how widened that pelvis is? Yeah. You'll know. Yeah.
It's like flattened out, it's separated in the middle, or what are you talking about?
Yeah, like right in the middle there where it has that big separation. I mean, if you look kind of on. Yeah. So you guys see right here, that is way more open than it should be. Okay. And then like.
I was looking at like the Mickey Mouse ears.
Here are some common sites of fractures. This one is going to be like your femoral head. fracture. This one right there. Yeah. It all depends on the mechanism, the patient, what they were doing, how it happened. Like, it's all going to play into what kind of fracture you have.
The one on the left.
Right? That's what there, the other one. There's like a smaller, little tiny thin
Where?
gap over here on the right compared to the other one. Yeah, right there in the middle of it.
So this one right here,
No, farther.
In the
In the
middle,
middle, yeah, right there.
that is actually not a fracture.
That's a
That's
hard
not-
one.
That's how it's normally.
Yes, sorry. Yeah, that is how it's normally. It's closed. Okay. So this, if I'm not mistaken, is what we call an open book fracture. So this is why when we teach you guys to do these physical assessments, we're not telling you to fillet the hips open, because think about, you have that fracture and now someone's putting pressure. You can cause that to open up more. Now, I will also tell you, if you put your pelvic binder on wrong, you can cause that to get worse too. Okay.
On that picture on the left, that their left femur, is that broken right there? That line that goes down right by the head? On their left.
Are you talking about
Over
this?
to your right? Yeah, that right there. That line down.
I'd say the other one was. Honestly,
And the other one does too.
I don't know. I don't know if that they would constitute that as a fracture or not.
Because the other one looks like it's rotated and on top of itself.
Yeah.
It certainly could be. There definitely could be more fractures in here. Like, I am not the guy to read X-rays. Mike Hoover can actually read the shit out of an X-ray. But the big glaring one right here is the open book. Yeah, he's in here somewhere. We can go over this picture later when he gets
Is
back.
there normally cartilage there? Is that what I'm seeing on the picture? In
Yeah.
the picture on the right?
Or
That?
what?
I didn't
That's
think
not
so.
showing the muscle, so you wouldn't see
Oh,
part of it
this.
in that picture.
I don't think there is.
Why is there that coloration or that space?
That's-
Because it looks like
You was.
for the hip ball joints, it looks like it might include
Yes.
the cartilage on that. Is there?
No, I just think that's the way the picture is, because this is straight bone, right? This is your femoral head, but that's just a size difference because it necks down in that femoral head.
It's a fibrocartilage.
Hey,
There he is.
quick question. Right here. Do you see anything else other than this fracture, and would you call that an open book? This right here? That up there? Okay. Surgical neck. Is that what you would call an open book fracture?
Yeah, I mean, like, I think they, like, nowadays they define it as like, not much, right? Like, I don't remember what it is, but like X amount of centimeters of separation of your symphysis, like it's.
Open book. Okay. And then I did not know you had cartilage here.
Yeah, right, so that symphysis, like it's held together with like cartilage, right? It's the same, like, your hip sockets, like you have cartilage.
So have you ever seen someone put a pelvic binder on wrong and cause a exacerbation of an open book fracture?
Oh yeah, like I've seen, like, even, like, right, like you do pelvic rap sheet, got hair on their wings, you know, like,
You want to basically.
So we're gonna go over pelvic binder placement, but you want to wear it like a mini skirt. You don't want it. What's the thing called that they used to wear? Corsets,
yeah.
right? You don't want it as a corset. You want it as a mini skirt. And if anyone wants to see somebody in a mini skirt, Mike Hoover is your guy.
That one. That's what you're referring to. Yeah, like to your question, right? Like feel your like iliac crest, like your wing, right? And then come down, like that big ball, that big bump. Like that is your greater trochanter. Like that's where you want that pelvic binder to be when you pull.
Yeah. So this is a pretty good illustration here of what a pelvic fracture would look like as far as the legs go. Okay.
Oh, where they're splayed like that?
Yeah, splayed, rotated out. It's a lot of vessels in there, right? A lot of potential for damage.
Are the white ones or?
They're all gray.
Probably. Did Mike talk about why pelvic binders work?
They just put that extra pressure to kind of.
It kind of puts it all back in place and gives like less room for it to bleed out. Okay.
Yeah.
This is the Sam pelvic binder. Like you just talked about appropriate placement, right? We don't want to wear it like a corset. It needs to be like a mini skirt.
So under the love handles, around the buttocks.
Yeah, and really you should be really feeling on your patients. Dig in there to feel those wings so that you can get in the right place. And then every pelvic binder is a little bit different. Like this one, you have to be, the diameter is a lot smaller, not diameter, the girth of it is a lot smaller. So it's going to put more pressure in a singular location. The ones we're going to go over today are a lot bigger.
The width?
Yeah, the width. Jesus, dude, my mind is not firing today.
Girth? That was your choice of
That
words?
was my
It was
choice
a
of
good
words.
word.
Okay.
It still works.
So if you guys look, like we just talked about in the top right, that's the Sam one. They're not bad. They're not my favorite, but they come in a lot of different sizes. So you have to carry a lot of them, and they're not as big. So you have to be way more accurate with them. These T-pods, the one to the left, the yellow one, that's the one that we carry here because you can use it for all ages, right? Like they're very versatile and you can adjust them to pretty much whatever you need. Like if Andy needed one, the teapot would be great. If somebody, like if you had like a little 10-year-old kid, the teapot would also work very well. Okay. And they do create quite a bit of force. And we're gonna work on that. Down here, what they're showing is a makeshift pelvic binder. I've seen them done a couple different ways. A lot of people just take a sheet and then like wrap it, tie it as tight as they can, and then knot it. Honestly, these things aren't that effective, just like makeshift tourniquets. If you're running on a service that doesn't have pelvic binders, and you're running on a shitty service. Okay. Oh God, I really hope I told you guys right since we're going over this, because if not, I'm gonna look like an asshole right now. Okay, anterior hip dislocation and posterior hip dislocations, rotation of leg inward and knee is bent. Okay, I did, right? Like rotated inwards, shorten. That's gonna be a posterior dislocation. Like I said, you can sometimes feel that in their glute. So don't be scared to go in and palpate the glute to like confirm your diagnosis. And then an anterior dislocation that's rotated externally. Generally, your fractures are going to present more like the anterior dislocation as well. Geriatric patients are more susceptible. Every ground level fall you go on with somebody over the age of 50, like you should be like high index that they might have broke their hip or dislocated something. Very, very, very common. It doesn't have to be a big trauma. It can literally be, I mean, dude, I think one time I went on your grandpa and he had like got out of bed and took a step and it went pop. And that was it.
He threw it out and sat down in his chair one time too. He tried to rotate his leg.
Yeah.
Popped it out, just sitting there.
Mm-hmm.
It's actually super common with people who've had a hip replacement. Like just even a simple this is enough. Like so, saying like to Mikey's point, like if they've had the hip replacement done before, like they don't need to suffer a trauma per se. Like bending over, turning around, sitting down in the chair is enough to pop it out.
Mm-hmm. And there's times where we can't relocate them and they have to go into surgery and a surgeon has to relocate it, and then sometimes they'll add in like caps and stuff to reinforce it so it doesn't happen. Hip fractures can present with localized pain, sensitive to pressure, exerted on the greater trochanter, discolored tissue in the surrounding areas, swelling, inability to stand, shortened and rotated limbs. And honestly, like a lot of these guys, not a lot, but like sometimes there's really not a lot of swelling. Sometimes there's really not a lot of discoloration. Sometimes it's just like what you see with the legs. Okay, we're padding in when we move these guys. We're going to pad I like to pad under their knees and then in between their legs. Just make it as comfortable for them as possible. And this is honestly, this is the stuff that paramedics forget because we're so gung-ho to give everybody pain meds. But it's the small stuff like this that really makes a difference.
You said pat under the knees and what?
I do. I like to pat under the knees if it's comfortable for them, and then in between the legs. Femoral shaft fractures, these are pretty nasty. Intense pain, like these guys will be hurting bad. Injured limb may be shortened, like we talked about the physiology behind it, right? It's like this, it breaks, the muscles do what? They still contract. The muscles don't know not to contract. So they're going to contract and make it shorter.
Why do you contract? Why do your muscles contract and spasm when you break?
So the body tries to splint itself.
Yeah, right. Like that's your physiologic splint, right? Same with like your ribs, like the flail chest you guys were talking about the other day. Like if you guys see a flail chest, that takes hours, right? Because like your intercostal muscles are trying to contract and splint that segment in place.
As we talked about, you can bleed a bunch of, what was it, a pint per leg, something like that, right? Or a pint and a half. You can bleed a lot into your femurs.
Isn't it 3 total? Wasn't it 2 up here?
Yeah, do you remember what it was specifically for the femur?
One
There's
pint
2
or
pints.
2 pints, that's right, because it's like 1 liter, I think, that you can do or something like that.
Yeah, it's 2 pints here and then 1.
Yep. If they have significant bleeding, you're going to control the bleeding. Obviously, that's first in your ABCs. Treat for shock, and then traction splints we'll talk about and go over. Mike, when you were flying, were they doing traction splints for open fractures? Open femurs, isolated femurs? And were you only doing them for isolated femurs?
Don't quote me on it. Like we had a debate about this. Like I want to, like there was a debate about whether or not to traction like an open femur.
Yeah.
And like some of it, like half the docs were like, yeah, do it. Half the docs were like, I'm not sure.
Yeah. Yeah, this is one of those things that's going to be changing if it hasn't. It has a high potential to change. And like I said, like if you just think about normal anatomy, right? Well, what happens if these contract? That means my thigh is going to get big, right? So you're going to have swelling in the thigh, and it's going to be shortened.
And then like we weren't doing like, right, because you wouldn't be able, like even with the new STSs or whatever, like you can have some lower extremity stuff, sure, but like if you have any suspicion of hip or pelvis, like you have nothing. So
I got yelled at one time for not putting a pelvic binder on and then tractioning after my medical director.
What do you pull off?
He gave me one of these, dude.
Did you ask him?
I don't even remember how it's like one of those where you like drop them off and then they have to say something to you, you know? They're like, oh, good job, but what about this?
Did they like having the patient live, or would they rather the patient bleed out?
I generally caution on the first one, but this is the thing about paramedics. They're a lot like doctors in the sense that they think they're hot shit and they all think they would do things better.
I will disagree with you, but I will say it is like paramedics where if you put 10 medics in the room, it's like putting 10 doctors in the room.
Yeah.
And you will not get them to agree.
No.
They will give you different answers.
Yeah. That's why the AHA takes so long to catch up in their guidelines, because that's how they do it. They put all the doctors in a room and then they can't agree on anything because everyone has doctor in the name.
Make that meeting a fist fight.
What they should do is just throw it into ChatGPT and go with whatever ChatGPT says. Okay. Cool. Any questions? No, everyone feels pretty good? Okay. 6 o'clock. That was pretty quick. I'm going to leave it up to you guys. We're going to exit out of this meeting. Thank you, Tina and Jessica. Have a great night. And it's up to you guys. If you want to stick around and work on pelvic binders and probably one too many traction points. If you want to do that, great. If you want to have the rest of the evening to yourself, like by all means, it's up to you guys. Okay. Good. All right. We're gonna take a little 10-minute pee break. because I've had to pee this whole time. And then those of you that stick around, we can get some work in. Those of you that don't, have a great day.
No, I'm staying. I have to go to work after this. I'm staying till 8.
About 9:30.
9:30.
Someone said that we don't actually have to be there until 10.
Who said that?
Last didn't get.
Someone from last class.
He said whatever.
Like Ryan or, not Ryan.
Yeah, that's because they were winning bucket, not that round.
No, what's this fuck? I hate the dude.
I don't know.
There's a lot
Nick.
of guys in there as well.
Nick was in the last class here.
Oh, Nick Hawley?
Yeah. Dick Holly.
Nick Hawley?
Santa Claus.
Yeah.
Oh, jolly.
It's windy. It's super windy in Crescent Valley right now.
They canceled practice for the Vikings for the games or whatever.
No, fuck them. I'm just gonna go push it.
He said, fuck no.
You?
Hi, Chipper. Oh yeah, your fucking brakes. What happened? What's the set consensus?
They're done. We're gonna
Who
get.
rode it today?
Huh?
Who rode? What, you live in town?
Yeah.
Okay. No, not too good.
Is it snowing?
No, it's windy as shit and it's starting to sprinkle.
That's it.
I have a rain mode. It's just letting it rain mode.
I wanna go home. 'cause
The
I
hell's
don't talk to my
That's so fancy.
It probably lowers it.
Fancy.
So that way you can't
my first day.
squirrel.
What is rainbow?
No idea.
Probably lowers the torque so that way when you hit it, it doesn't scratch your screen.
That's
Never rode in the rain.
Get tested out.
Yeah.
That's cool though.
It has a standard, a sport, and a rating.
Yeah.
It hangs on standard all the time.
I don't know what it is, but no. If I just stay here just because I don't wanna go home and do the kids' dinner, I want the babysitter to do it.
What the fuck, dude? Hey, Shia, can you drive to the Lucia?
Yeah.
You might wanna go a little bit back, you know? It's not raining right now, but it's going to.
Thanks. What? You're always laughing at something.
Those ones are fucking expensive too.
Turn around and walk away. So, so this is our
Okay.
But would that be considered what you're doing or not?
No, like. Yeah, so this is where I have a patient with
been shacking and a pelvic fracture. The doctor wanted me to do a pelvic binder and then do a traction spline.
Oh, it's working its way up. Oh, it's a biggie.
Yeah.
So does that basically?
Yeah. It's right there.
Cool.
When I looked at it earlier, I thought it was coming. They hit Antelope Valley. It's coming, Mikey. It's coming.
What?
This shit.
I'm going home, brother. Someone else's problem.
Oh, there's two right on 80. Looks like one hits the freeway. Just outside town.
All right. How many did we lose? How many we got?
I think you still have everybody.
Yeah, I don't think
Shit.
we lost anyone.
Fucking go-getters, dude. Making me work today. If everyone would have left, I would have went home. But now I'm here for y'all.
Hey, I have to work as soon as we leave here, so.
Oh, so you're taking your
I'm
sweet time.
sweet time, buddy. Sweet time.
Here to learn.
Yeah, you do.
He has to go with me.
No, listen, man.
That's all good, dude.
Watch, he's gonna text Eric. These motherfuckers stayed to get out of work. There goes 2 of your PTO hours, and we get rid of hour.
I have enough hours where I'm not even concerned about it at this time.
187 or something.
Library was just open?
Yeah, 87 hours.
I should shut up. Yeah, thank you.
I'm at 107 now. Hours of PTO.
107 hours of PTO?
Yeah.
Shit.
Hey,
Is that good?
Hey, but we get 13.25 a month.
It's not bad.
Whereas my,
Yours is combined, right? You don't have like vacation and sick.
no, it's all just PTO.
Oh.
So we don't have sick pay. We don't have, well, we have like FMLA.
Do we get 20 hours a month?
Ours are separate though, aren't they?
Are you at, what are you at, 8 right now? Are you getting 8 or 10 vacation?
8, I think.
So you get 10 sick leave till you hit 10 years, and then it goes up to 12,
Oh, yeah.
and then
Oh, really?
vacation goes up like every 3.
I think ours is 1 year to 3 years.
Okay.
Or 1 to 4, and then 5 to 9.
We have everybody back? Okay, you're going to rotate through 3 stations.
Wait, can I be the patient for the traction split?
I'm not running traction split. That is Mr. Hoover's. This could be Mr. Hoover's call, see how he wants to do it.
You want to be the patient?
Yes,
You don't want to do the.
I've got this one hip, and anytime there's a traction splint, like training wise, it makes it so much better.
Yeah, no.
They do have the second.
I know.
7.
Oh, it was the new ones? Yeah, cool. So we're gonna end up splitting you guys in groups of 3. Group 1 is gonna stay in here with Michael Hoover, and you're gonna go over traction splints. Group 2 is gonna go into the kitchen with CJ working on sling and swath and splinting. And then group 3 is gonna come with me in the day room, and we're gonna go over pelvic binders. Okay? Good? I'm working on it.
1, 2, 3.
I need to get my timer out.
Yeah.
And we'll do CJ 30 minutes apiece. Does that work?
A little long,
Oh, that is a little long. Dude, that's a little long. We'll do 15 minutes apiece. Okay. Okay. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2. Work. And then just rotate. Like if you start in here, go to the kitchen. If you go to the kitchen, go to there. Like rotate in a clock.
So this is group 1.
For group 1?
Yeah, and here's group 1. 2's in the kitchen, 3's in the foyer.
Oh, I thought he was just meant like these 3, then those.
No.
3. Okay.
I am 2, like, and you're 2.
Oh, we're supposed to go by our numbers?
Yeah, see, look, see, she had the same idea. I thought it was like
One's in
these
here.
people on before they're here.
So we're all ones. Okay.
I'm a 10.
Group 1, Mike will take you in this room in here.
One?
Yeah.
He didn't. He said stay in here. He
Yeah.
said group 1 will be in here. Oh, this way. They
Oh, the
moved them.
lounge, the lounge.
They moved them.
So that's like basically a plastic sheet.
We're both in the principal. We were
No,
just
not that office, the other office. Bureau, that one. Really, bureau.
I want to know if there's such thing as internal Tourette's. You know, like you have people.
Okay. If you guys want to colors, you can.
Okay. Thanks.
Where you yell at yourself on the inside?
Well, like, okay, so people with Tourette's, right? That's like a tick. But if you can have a tick inside your head instead, where because like I have, I swear I've got fucking Tourette's, it just doesn't come out. Like it just like in my head, it's just like Inspector Gadget. Gotta go through. It's not just that. It's like oh, and I don't know if that's a normal person thing or if I'm just fucking crazy.
What is normal now?
I don't know. That's the
Well,
problem.
that's right on that one. Well, y'all have a great night.
You too, drive safely.
It's all good. I'll figure it out. It's all good. You're good. I'm out of time. Yeah. That's all right. Love you, bye. It is what it is, Rick. Yep.
Good.
Yeah.
I still have popcorn.
It's all right.
I want to get away. Get out of here.
I ride my bike. Great. See what happens. I haven't done it before. Take it slowly.
How far do you live?
Couple of minutes away.
Couple what? What?
Couple of minutes away.
Yeah, I'm fine. Just don't do anything crazy. If you want, I can drive you home and you can go get it tomorrow. You don't have to ride in the rain. To you.
Thank you.
You know, like a good neighbor, Shia's there.
Yeah.
That was hard. I sitting there learning. Yeah, they're going over the vacuum first.
How's that?
Oh, that's right. Oh, Andy's across the street now. That's quick.
And,
Yeah, he's on right home.
oh, is he?
Yeah.
Andy must still be here. I think that's Andy's stuff, right?
Yeah, he's riding on the ambulance.
Oh, that's
Yeah,
right.
yeah.
Shit, I forgot.
Good work, Lakin.
Thanks, bye.
wider than normal.
Yeah, they're all left on. If you can at least turn that off.
That's not.
Yeah, let's turn the computer off too. It needs some downtime.
Let me just close it.
No, actually go through the shutdown process.
Which button is it for the projector? Just white one or
The blue one, but you do it twice.
the blue one?
The blue button.
Oh, and this, okay.
Yeah.
Oh, that's what I was asking. It's like, on like a small body like that, a frame?
Yeah, stickers.
Yeah.
Yeah.
I was kind of like, shit.
How do you fuck you turn this off?
I was trying to hurry, but I was trying not to.
No, dude. So when it comes to like patient care, like I don't know if you felt it, but CJ gets a little amped, you know, and that is, you want to be just fucking steady, you know, like do what you do in class, slow is fast, fast is smooth, you know, because that's where you miss things. Like we miss lung sounds because like things were just like you feed off other people. Like CJ's my boss, so I was feeding off CJ, and like you want to be fucking.
Yeah, and I didn't want to get in your guys' way
Yeah.
either. That's my problem, is not getting in other people's way.
No, dude, don't think about that, dude. Like you're. How the fuck do I turn this off?
The little 4 squares on the left,
This
or
one?
on, yeah. Then right,
Oh, right here.
or your left, yeah.
This one right here?
Yeah.
And then,
Then shut down, I think you said.
okay.